right, let's go ahead and jump in. Good afternoon or morning, everybody, depending on where you're joining us from. Thank you all so much for being here over your lunch hour. We'll go ahead and get started. Just a few quick introduction slides, and then very excited to introduce our speaker today. So just a quick overview of what Project Echo is. It's an educational telemonitoring model that uses video conferencing to leverage case-based learning and the sharing of best practices to get knowledge to the right place at the right time. They have an all teach, all learn model, and we are adapting this model at Denver Health just to increase our access to other communities, promote consistency, increase our professional knowledge, reduce inequalities, get information out there quickly to you, and reduce isolation. So just a few helpful tips. So mute your microphone when not speaking. If you are on camera, just a reminder to position your webcam effectively and communicate clearly through the session. And please use the chat function. Highly encourage you to send any questions or comments you have through there. And if you have any IT issues, just feel free to message me privately or reach out to my email linked here. As you probably saw, this video is being recorded. So by participating in the session, you are consenting to that. All right, so let's jump in. So my name is Ariana Boschera. I am one of the hub members at the Denver Health Project Echo Funky Bug program. If you wouldn't mind just putting your name and role, organization, if you'd like, in the chat so we can all get to know you a little bit better. And then finally, I just want to introduce our speaker, Dr. Guillermo Rodriguez Nava. He is an infectious disease physician for the Associate Director of Infection Prevention at Denver Health and is an assistant professor of medicine at the University of Colorado School of Medicine. He's originally from Mexico City, where he earned his medical degree from UNAM School of Medicine. Before completing his internal medicine residency at Ascension Health in Chicago, and his infectious diseases fellowship at Stanford University, where he focused on hospital epidemiology and infection prevention. His academic interests center on genomic epidemiology, artificial intelligence, and diagnostic stewardship. Outside of his professional work, he enjoys salsa dancing. So with that, I'm going to stop sharing and pass it over to him. Thank you so much for being here today.
All right, thank you. All right, hi everyone. My name is Guillermo. Can you see the slides?
Yes, we can see them. There's a bit of a box, but it seems to be clearing.
Okay, hopefully it's all right now. Alrighty, so I have nothing to disclose. And Feliz Dia de los Muertos and Happy Halloween, everyone. Dia de los Muertos is a day that we used to remember people that is no longer with us, usually loved ones or family members, but I think it can also apply to people that impact our lives. And taking care of this patient impacted my life in many ways that I couldn't imagine, professionally and personally. So I cannot think of a better way to honor this patient memory than with this talk. So let us start. So this is a female in her 50s that presented with 2 months of weakness, anorexia, vomiting, myalgias, and arthralgias. She has been having intermittent fevers and unproductive cough for about a week. And then for the past day, she's been experiencing abdominal pain and 2 episodes of vomiting. She has been seeing a few doctors in the past. She's been in 2 hospitals for unspecific complaints, but without a diagnosis. So the medical history and presentation, she has a history of hypertension, anemia, and vaginal prolapse. Surgical history, she doesn't have any. Then she's not taking any medications. And then she mentioned not having any allergies that she's aware of. And the patient is originally from Mexico, but she doesn't speak Spanish or English. She speaks an indigenous language. And up until a few days after admission, the chain of communication had to be patient she needed to talk to the son, and the son will translate from the indigenous language to Spanish to an interpreter, and then the interpreter will translate from Spanish to English. So you can imagine the broken telephone here and the lost information, at least for the first few days. So on presentation, she was febrile, 38.9 Celsius. On exam, unremarkable for the most part, but some temporal wasting. She was fully alert, oriented, no respiratory distress. And then the admission labs with normal white count, hemoglobin at F.1, C-reactive protein elevated, and a sodium of 112. And they obtained X-rays that show this multinodular miliary pattern. So she's admitted to the intensive care unit with severe hyponatremia mainly, but she's also started on broad spectrum antibiotics, namely cefepime and vancomycin for the findings on these X-rays. And then because of these X-rays, they also obtain a CT scan of the chest that show these diffuse pulmonary nodules. So this is the infectious disease trifecta. I think it's an oversimplification at times, but it helps you in a structured way to think about the potential diagnosis when you have a mystery case, kind of like this. So we have a clinical diagnosis of diffuse pulmonary nodules with constitutional symptoms in an immunocompetent 50-year-old Mexican indigenous woman that, as far as we know, she's from Mexico and has lived in California for some time. And happy to hear, or you can think about differential diagnoses or just put it on the chat. I just give a few seconds. Alrighty, so the differential is quite broad at this point. It goes from regular bacterial infections to mycobacterial, fungal infections, viral infections like SARS-CoV-2. But when the pandemic started, I was actually a first-year resident, and a lot of the X-rays that we saw look like this. So it is possible, and of course, you have always to think about non-infectious syndromes. So additional investigations sent by the admitting team included blood cultures that were no growth, coccidioides, IgM, IgG, enzyme immunoassay that was negative, histoplasma antigen was negative, blastomyces antibodies also negative, aspergillus galactomannan negative, and elevated beta D glucan, and an HIV antigen antibody test was sent, but it wasn't resulted yet. And then respiratory viral panel showed parainfluenza virus 2. A dedicated SARS-CoV-2 PCR was negative. Respiratory cultures showed oral flora, and then 3 sputum AFBs and 2 Mycobacterium tuberculosis PCRs resulted negative. And then from urine, histoplasma antigen was negative, and Legionella urine antigen was also negative. So it wasn't until hospital day 5 that they consulted infectious disease. And it wasn't actually the primary thing who did it. It was one of my co-fellows. She was doing the elective of antimicrobial stewardship, and she realized that these patients had been 5 days on broad spectrum antibiotics. And they haven't figured out a diagnosis. So she recommended an ID consult. So Spanish is my primary language, as you probably can imagine, as I pronounce it anemia instead of anemia. But I was able to break the chain of communication a little bit, speaking to the son in Spanish, and then through the son speaking to the patient a little bit better. So after talking to the patient, we figured out that she was born in Oaxaca, Mexico, in a region that is called the Mixtec region, and she's from an indigenous community named Triqui. And she moved to northern Mexico around the year 2000. And then from there, she moved to Merced, California in 2007. And then from there, she moved to Soledad, California, where she's currently living with one son. So this is a map of California. If you're not familiar with the geography of California, the 2 stars here represent Merced and Soledad. Merced is just east to San Jose, and then Soledad is south Merced, and there is where the patient is living with the son. And she told us that she's always been working in the fields, like picking up vegetables from the ground and whatnot, until a few months before our presentation. And then she also told us that her husband died in Mexico of an unknown disease in the 1990s. They don't have pets at home, and then there's no sick contacts that she is aware. And a little bit of Mexican geography here. On the left, you can see a map of Mexico, and the Mixtec region is near the Pacific coast, is a mountainous region when there's some other indigenous communities. But the Triqui are very well known for two things. They like to wear these red clothes, and they're also very good at playing basketball, but they like to play basketball without sneakers. And hospital days 6 and 7, the patient continues having fevers. She didn't have any respiratory distress. She was becoming weaker over time, and we had asked pulmonology for a bronchoscopy, but all this workup was delayed because it was a holiday weekend. And we got additional results. The HIV antigen antibody finally came back positive, and at the same time, we had a viral load of over 1 million. And then, given these results, we recommended more testing that included a Cryptococcus plasma antigen that was negative, repeated coccidioides, IgM and IgG enzyme immunoassay that was negative, Aspergillus species and dimorphic fungi, plasma cell-free DNA PCR was also negative, and MTV plasma cell-free DNA PCR was also negative. And given the context of HIV and the lung findings, it was important for us to rule out pneumocystis jirovecii pneumonia. So we ordered a plasma cell-free DNA PCR that was negative, and it's a lab-developed test at Stanford that has very good sensitivity and decent specificity. So I think the infectious disease trifecta has changed a little bit by this point. We have a diffuse pulmonary nodules with constitutional symptoms in a patient with advanced HIV. So this is an immunocompromised 50-year-old Mexican indigenous woman that has been a field worker for most of her life, working in Central Valley, California, and Northern Mexico. So I think we can narrow the differential a little bit. And the two bugs that we had in mind at this point was Mycobacterium tuberculosis and Coccidioides immitis/Posadaceae. And in fact, after we interviewed the patient during the first consult, we just decided to start the patient empirically on TB treatment and Coccidioides treatment. And we had other infections lower in the differential at this point. So hospital day 8 to 10, as I said, the patient was started on empiric 4-drug therapy for TB and fluconazole for coccidioides. We got additional results. The total lymphocyte count was 270, and the CD4 count was 30 with 11%. And then that weekend, when I was doing my rounds in the morning, and I went to see the patient, I saw that she had an acute change in mental status. So a code stroke was called, and a CT head was obtained that showed new hypodensities, which triggered an MRI that showed lectomeningeal enhancement, multifocal vasal attenuation, and then multifocal parenchymal T2 abnormalities that were consistent with meningovasculitic encephalitis, probably infectious. So because of this, the patient underwent a lumbar puncture, and CSF fluid was sent for analysis. So the opening pressure was normal. She had an elevated Y count on CSF, 45% neutrophils, low glucose, and a protein of 278. And an MTB PCR from CSF was negative, and a cryptococcal antigen from CSF was also negative. Aspergillus PCR from CSF was also negative. And then the meningitis encephalitis panel was also negative. And I should mention two things here. So the MTB PCR is not very sensitive for the diagnosis of TB meningitis, and the cryptococcal antigen is actually more sensitive than the PCR for the diagnosis of cryptococcal meningitis. But a couple days later, we confirmed the diagnosis with another CSF PCR. The dimorphic fungi PCR came back positive for Coccidioides immitis / Posadaceae. This is another Stanford lab developed test that looks for the highly conserved genes specific for Coccidioides. But we also got the diagnosis with a Coccidioides antigen validated test that was also positive. So what happened next? The patient had been on fluconazole for some time, but we decided to start liposomal amphotericin B, given the disseminated disease, and high dose steroids for CNS vasculitis, probably due to coccidioidomycosis. And then we had planned to start antiretroviral therapy 14 days after starting antifungals. And I should also mention that at this point, she was still on treatment for TB meningitis because the cultures weren't finalized yet. But after I reviewed the charts, a few days later, they weren't positive. And she was also receiving penicillin for syphilis. But at the end, the patient decided to just discontinue all treatment, and she was discharged on hospice. So the final diagnosis that we have is disseminated coccidioidomycosis and advanced HIV. And coccidioidomycosis incidence is increasing, and I think that's the importance of this talk, more than this being a pathogen with pandemic potential. And this is just data for the past 20 years, and you can see the incidence is on an uptrend. There's a couple of outliers between 2010 2012, but even if you remove those outliers, you can see the uptrend. And the most of the cases are in California and Arizona, but there's multiple states that haven't had cases before that are reporting autochthonous cases of coccidioidomycosis, meaning people that didn't travel to Arizona or California that developed the disease. And this disease has an interesting story. So the first official case was reported by Dr. Alejandro Posadas in Argentina back in 1892. He reported the case as a case of mycosis fungoides, but he believed that the problem with this patient was mostly malignancy, but it was triggered by some sort of organism that he thought it was a protozoan. And then in North America, Dr. Emmett Rixford, who was an associate professor of surgery at Stanford School of Medicine, presented or described the second case and the first case in North America. And the difference here is that he had a stronger suspicion that this was, in fact, an infectious disease and caused by a protozoan organism that he named Coccidioides immitis. And then he named Dr. Posada's pathogen as Coccidioides posadaceae. No, actually, he named it Coccidioides pyogenes. And a couple of years later, we figured out that it wasn't a protozoan, but a fungal organism. So let's talk about the bug. Coccidioides is a dimorphic fungus, and there's two species, Coccidioides posadaceae and Coccidioides immitis. And this organism evolved around 12 million years, and it's thought that Coccidioides posadaceae is the more ancient organism, and it originated in North America and then disseminated through the continent via small mammals. And at some point, Coccidioides immitis separated from Coccidioides posadaceae and established in California and Arizona. And as I mentioned, Coccidioides is a dimorphic fungus. And what this means is that it can exist in two forms, a so-called GIS form and a mole form. And on the top left, you can see the quote-unquote GIS form, which for Coccidioides is a special form. It's actually called spherical. And then on the top right, you can see the mole form, which is also special for Coccidioides. This is an arthroconidia. And arthro means jointed, so it's basically a hyphae or hyphal elements with joints. And on the bottom left, you can see the mole form growing in a plate. And this is actually important because this is the infectious form of the organism and it's very contagious. You just need the one spore, the one arthrochonidia to get infected. So people in the micro lab need to handle this with a lot of care. It is actually recommended that you handle this in a biosafety lab level 3. And then on the bottom right is the spherical form in tissue. And you can see these small dots within the spheral that are called endospores. And then when this spheral breaks, it releases the endospores and that perpetuates the infection. And it's worth mentioning that this form is not infectious. So pathologists handling a biopsy or medical examiners doing autopsies cannot get infected with this. And in fact, when I was an infectious diseases fellow and also a hospital epidemiology fellow, one surgeon called us once because they were concerned after doing surgery on a patient that they thought had cancer but ended up having coccidioidomycosis. So he was asking if he had any risk of being infected, which of course he didn't have because it's not infectious. So in terms of the exposure, this is a pathogen of the New World. It's only located in the Americas. And Coccidioides posadaceae is located throughout the continent from the United States all the way down to Argentina. And Coccidioides imidis is only located in California and Arizona and a little bit of New Mexico, some cases reported in Washington state. And this fungus inhabits what they call a lower Sonoran life zone, which is a hot, arid desert ecosystem that is characteristic of the west of the United States and northern Mexico, the southwest of the United States and northern Mexico. And the soil has also special characteristics, is very alkaline and it has a lot of salts. And this is important because coccidioides grows in the mold form in the soil. So anything that disturbs the soil can aerolize the arthrochonidia, and then any mammal that is nearby can get infected. So the mechanism of transmission or of acquiring this disease is airborne, but it's not contagious person to person, with one exception. So you can see how anything that disturbs the soils can aerolize these arthrochonidia, and then if you are close by and inhale this, you can become infected. And this can go from human activities like construction or agriculture, like our patient picking up the vegetables from the soil, or natural phenomena like a dust storm. This is just an example of a dust storm in Central Valley, and you can just imagine the millions of arthrochonidia that are flying around, and you just need the one to become infected. And then, as I mentioned, it's generally not transmissible person to person, but with the exception of vertical transmission from mother to offspring, there have been several cases reported in the literature, either hematological or transplacental transmission. And then climate change is it's expanding coccidioides range. This is a map from the 1950s that showed the endemicity of coccidioides in the United States, pretty much limited to California and then Arizona, a little bit of Texas and New Mexico. And this is an updated map where you can see the range has increased. It's going north and east. And how much this will change, I'm not quite sure, because besides the climate change, you also need changes in the soil because this fungus grows in a very alkalinic soil with a high salt contents, but we have seen an increase in range for the past few years. All right, how about the host? Who is more susceptible to develop this disease and its complications? So we have seen that males are more likely to develop the disease and its complications, and this is not unique to human males. This has been shown in non-human primates as well, and dogs. So we're pretty confident that there's some hormonal component to this. Immunocompromised patients, this is an important population, a growing population. We have more and more immunosuppressants and a lot of more patients on cancer therapies that lead to immunosuppression. And then ancestry is important. Some very old studies figure out that people with Filipinx ancestry, African American, or Latinx ancestry had a higher risk for developing this disease and its complications. We're not quite sure why this happened. Can be a little bit of genetics and a little bit of healthcare inequities. So the good news is that most cases are asymptomatic. Around 60% of the cases are asymptomatic plus minus confidence intervals. And then the rest will develop either pulmonary disease, or a very few of these cases will develop extrapulmonary disease. And what coccidioides likes to do is to go to the skin, the bone, or the brain. Both these are the minority of the cases. And in terms of the spectrum of the disease, the pulmonary disease, that is, it can present as an acute pneumonia, respiratory syndromes, community-acquired pneumonia-like syndrome, or this happens in 1/3 of the cases, and then the rest can develop nodules or cavities or chronic fibrocavitary disease. And then there's a term that people use interchangeably in California to describe coccidioidomycosis. Some people call it valley fever overall, but this term specifically applies to a form of the disease that is subacute and respiratory with cough and fatigue and joint pain. And then there's another term that you may hear around. It's called desert rheumatism, which is the triad of fever, erythema nodosum, and arthralgias, and not necessarily respiratory disease. And the take-home message of this slide is that in a patient with pneumonia, the right epidemiological factors, a rash, in particular erythema nodosum and eosinophilia, you have to put coccidioides like top on the list. And the diagnosis of this disease is quite old. It still relies on antibodies and antibody testing. And most of the workflow include a rapid, highly sensitive antibody screen that reflects to a couple of other tests. Getting cultures and biopsy from these patients is not always feasible, and it has a low sensitivity. So the majority of the specialty labs, what they do is they do an enzyme immunoassay to look for the IgM and IgG antibodies, and it has a good sensitivity, high sensitivity, and a good specificity, and they're very fast. You can get a result very, very quick. The problem is the performance characteristics in the immunocompromised patients is lower. For instance, in HIV patients, it has been described that sensitivity drops down to 25%, and this kind of explains why our patient had 2 negative antibody screen tests. And then if an antibody test comes back positive, what the specialty lab will do is to run 2 tests. The first one is what they call an immunodiffusion, which is basically a gelatin plate with a coccidioides antigens and controls. So they put the patient's serum in the middle, and if there's antibodies, the antibodies will diffuse and will try to reach the antigen, and the antigen will also diffuse. And you can see this white band like in between the antigen and the patient serum. It has a very poor sensitivity, but it has a very high specificity, and it's used to confirm the diagnosis. But it's a very tricky test to do. It takes some time, more than 24 hours, and you need trained personnel to run this test because it's very user dependent. And the next test, or the other test that is done in these specialty labs, is called complement fixation. And this test has a good sensitivity and a good specificity, but its main purpose is not to confirm the diagnosis. This test is used for staging, prognosis, and then to follow the response to antifungals. And it's a very complicated test. I always get very confused, and I'll try to explain the best I can. So you have coccidioides antigen and erythrocytes and a complement. And then you have the serum of the patient that you are testing that supposedly has the antibodies. So if there's antibodies, the antibodies join the antigen, so the complement is busy binding the antigen antibody complex, so it cannot lyse the erythrocytes. So they keep doing dilutions up until a point that there's no longer antibodies in the sample, so the complement can join the erythrocytes and they get lysed. So what they do is they report the last dilution that had antibodies. In this case, will be 1 to 64. And then you can train this lab in time to evaluate the response to antifungals, but also the higher the antibody titers, the worse the prognosis. And other tests that are worth mentioning is the antigen. This test it's particularly useful for coccidioides meningitis and immunocompromised patients, and you can see that the performance characteristics are way better than immunodiffusion and complement fixation. And this is the way that we were able to confirm the diagnosis in our patient beyond the PCR, and that's the other test that I'm going to mention, a fungal cell-free DNA PCR. This kind of test is very, very unique, lab developed. Very few institutions have this available, and the performance characteristics are not very good, not very good sensitivity, very high specificity. Alrighty, and in terms of treatment, the treatment is not always required, and we have guidelines for coccidioidomycosis. They are quite old, but I don't think much things had changed since 2016, and they may be on the work to try to update these guidelines. But these guidelines mention that patients that with mild disease will usually recover on their own, except for a few cases. And they say that patients with debilitating illness, not very specific term, but probably they mean patients that they need to get admitted to the hospital, or they are admitted in the ICU, they have very severe disease or disease that interferes with their activities of daily living. Patients with comorbidities, especially those immunocompromised, but also they mention patients with diabetes, patients with heart disease that could probably not tolerate a very bad lung insult, and then pregnant people. That's not a comorbidity, but it has been shown that they have a higher risk of developing coccidioidomycosis complications. Then people with certain ancestries, as we discussed before, African Americans, Filipinx, and Latinx people, they have a higher risk for disseminated disease. And then patients that are diagnosed with disseminated disease from the start. And the treatment of choice is an orally absorbed azole, and the guidelines that I just mentioned recommend fluconazole, but there is a problem with this. And perhaps this is something to take into consideration in the update of the guidelines, is that fluconazole is the least potent agent when you test it in vitro as compared to other medications like atraconazole, posaconazole, voriconazole, but remains the standard of care with a few special considerations. For instance, liposomal amphotericin B is recommended in a patient with a critical illness or a very severe disease like our patient. There have been retrospective studies that show that patients with bone and joint disease do better with itraconazole as compared to fluconazole. And then there is the non-resolved issue of intrathecal amphotericin B, or injecting directly almost into the brain amphotericin B. And this is a little of self-service. A couple of fellows and I published a paper just recently on the experience at Stanford University on intrathecal amphotericin B, and these patients didn't do very well. And so they did it in the patients that receive high-dose corticosteroids. And perhaps it is very likely that there is some selection bias here because these patients were sicker, but this continues to be an unresolved issue. There's a lot of contrasting opinions whether to use intrathecal amphotericin B. All right, so despite this, most people will recover. That is, people with not disseminated disease, around 99% of people will recover. In the case of patients with non-CNS disseminated disease, this is a little bit lower, 85% of them will recover. And then the worst case scenario is patients with central nervous system disease or disseminated disease. Around 13% of patients will survive after 15 years. So the majority of them will perish within 50 years. And of course, immunocompromised patients, they have a higher risk of worse outcomes, progressive infection, death to coccidioidomycosis, hospitalization, and disseminated infection. And I think I forgot to mention that treatment duration is very variable. If you have a patient with uncomplicated pulmonary disease and you decide to treat, treatment duration is usually 6 weeks, but it can go from 6 weeks to lifelong therapy. And that's the case with patients with coccidioides meningitis. And again, there's not a lot of studies on this. The landmark paper was from the 1990s, and a small cohort of 18 patients where they stopped antifungals in 14 of those patients, and they have relapse of coccidioides meningitis. And just from an empirical experience, my own observations as a fellow, I had a few patients that something similar happened. They had relapse, and even on treatment, they can have a relapse of the disease. So it's a very hard disease to manage. So in conclusion, coccidioidomycosis is a re-emerging infection, and a lot of things are in play: climate change, human activity, and people being able to recognize the diagnosis better. Of course, still travel and residence history is crucial when you are evaluating a patient with a pneumonia or respiratory illness, with a rash and eosinophilia. And then the risk varies among individuals. Different patients have different risks. A healthy patient probably will not even figure out that they had coccidioidomycosis or require treatment just for a few weeks, as compared to other patients that will probably require a longer treatment or lifelong treatment. And this is all I have, and happy to take any questions.
All right, please feel free to either put your questions in the chat or come off mute if you'd like.
Guillermo, Heather Young here. Thank you so much for presenting this a really amazing case and sharing it with us. I also love your observations that cocci is increasing in its geographic area, both worldwide and in the US. And I think that your comments about the soil and about really the way that humans interact with the environment is just so interesting.
Yeah, thanks, Heather. Yeah, it's a very interesting fungus. I think it's my favorite fungal pathogen.
I was also really interested with your comment that it seems to be more males who develop cocci rather than females, and that's seen across species. Initially, when you had said that, I had just maybe incorrectly assumed that maybe it's more men who have landscape and outdoor exposures than females, but I think it's really interesting that it persists across other mammals as well.
Yeah, yeah, absolutely. There seems to be a behavioral component. They have seen that, for instance, in these primates, male primates in the New World dig more than female primates. And obviously, as you mentioned, there's more males in construction and this kind of work. But there's been some studies at UC Davis, Dr. George Thompson, and they have seen that when they castrate dogs, the risk pretty much becomes equal between male dogs and female dogs. And they also published a study where they look at the incidence like very early in life in humans, and then when they hit 14 years of age, and they start having more hormones, the risk changes, and the graph continues to go up for males, and then for females, the incidence is kind of the same or a little bit lower. So I guess it's fair to say that there's an hormonal component.
Yeah, that's really interesting. I had one other question for you that's sort of unrelated to cocci, but related to this patient's HIV diagnosis. And
Yeah.
with the convoluted communication strategy that had to be used between her and her son, tell me how you approach that challenging conversation.
Oh yeah, absolutely. That's another. Thank you for the question. So I think the diagnosis of HIV is is difficult, and the conversations with the patients are always very difficult, and you have to respect their privacy. So the interesting fact here is it's that in California and actually near to Stanford, there is a tricky community. So I don't know. There's some communities in the United States that I cannot explain. I don't know why some people from Mexico like to go to Connecticut or some other cities. So the tricky, they like to go to California. So there was actually a interpreter, an authorized interpreter. So after like talking to the patient and getting the initial history, when we needed to ask specific details that were more personal, we have to go through the interpreter. But that wasn't available at the beginning. It took some time to get one, but there was one.
Oh, that's really great. Thank you for sharing that. Yeah,
Of
with
course.
such tight-knit communities, there can definitely be other challenges there, but certainly way better than doing it through her son. So
Yeah,
awesome.
absolutely.
Any other questions from the group? All right. Well, with that, we can go ahead and wrap up. Huge thank you to our speaker today. Really interesting presentation given, and just appreciate you being here and sharing your time and knowledge with us. So thanks so much, and I hope everybody has a great rest of your Tuesday.
Thank you for having me.
Thank you.
Bye-bye.
Bye.